Hello. Today I'd like to do a short integrity session on restraints. Restraints by definition includes any device that restricts a patient's voluntary movement or access to his own body, and it can't be easily removed by the patient. Again, anything that restricts the patient from moving as they desire is considered a restraint. Many people only think of physical restraints such as mittens or vest or any kind of tie that physically restrains the patient. We should also remember that a medication may become a chemical restraint. If a person is yelling out or continually gets out of the bed and the nurse medicates them with a sedative or an antidepressant, that medication may be considered a restraint. It is therefore unable to be used for that purpose. A mechanical restraint can be something as simple as a lounge chair that's fully reclined so that the patient cannot freely come back to the upright position in order to move. Putting up side rails, especially the 4-point side rails, where there are side rails at the head of the bed as well as at the foot, is considered a restraint. It is not considered a safety device. It is considered a device that restricts the patient's movement, and therefore all side rails may not be up unless there is a medical order. For a restraint to be legally used in a medical facility, there must be a physician's or a nurse practitioner's medical order. This order is valid for only 24 hours. After that period, the patient should be reevaluated to see if the restraint is still required. If so, the physician or the clinical nurse practitioner must rewrite the order. Restraints are used only for 2 reasons. First, if the patient is considered a danger to himself or to others. So, a patient who has become combative and is in danger of pulling out their intravenous device may require restraint. Secondly, if the patient must be temporarily immobilized for a procedure. This would include those situations in the operating room where the patient was premedicated or sedated and then placed on a narrow operating room table. In order to prevent the patient from falling from the table, the nurse may apply a safety strap across the patient's thighs and across the patient's arms. Again, this is a temporary device. A restraint should never be used for the convenience of personnel. So, if a patient is considered combative, but they are not a danger to themselves, they have not exhibited combative behavior for a period of time, or if they're simply yelling out, the nursing staff may not call the physician to request a restraint because indeed the restraint is not considered necessary. What may be considered necessary is that the patient may need some kind of alternative supervision. This may include interventions such as bringing the patient out to the general area near the nursing station so that the patient can be more adequately supervised at all times. Or it may be as simple as contacting the activities director and taking the patient to a group activity because they may be yelling out because they're bored. Again, we should not consider the patient to be a nuisance and have to be restrained because it interferes with our routine. If, after all alternatives to a restraint have been exhausted, the nursing staff should contact the clinical nurse practitioner or the physician to obtain an order for restraint Remember, the assessment must be done by the professional nurse, either the RN or the LPN. The unlicensed personnel may, however, apply the restraints. Restraints must be applied so that no circulation is cut off, so that they should not be so tight that the personnel cannot get at least 2 finger widths between the restraint and the patient's skin. Once the restraint has been applied, it should be tied not to the side rail but to the bed frame or the chair frame, so that when the side rail is let down, it doesn't tighten the restraint against the patient. The restraint should also be tied with a safety slip knot so that it can be easily removed or released in the case of an emergency. Once the restraint is applied, the patient must be checked every 30 minutes. This should not be delegated to the unlicensed personnel. Assessment is always a professional nursing skill. So the registered nurse or the LPN should assess the patient's circulation every 30 minutes, and they should check for dusky, pale coloring, coldness, absence of pulses in those areas that are being restrained. Secondly, they should check for full intact skin. If the restraint is so tight that it has rubbed off portions of the epidermis, then this should be treated, and the restraint should not be applied to that area that's been injured. At the same time, every 30 minutes, the nurse should reevaluate if the restraint is still necessary. We need to remember that most facilities are now zero tolerance for restraints, which means that the restraint should be the last resort. Other things should be tried in order to distract the patient, to supervise the patient, and one of these alternatives may include calling the family to have someone come in and sit with the patient at all times. We should try to do everything we can to avoid placing a patient in a restraint. Remember that restraints have been fatal. If a patient has been restrained and they really want to be released, some patients have even crawled between the mattress and the side rail and have become entrapped, have choked, or have been suffocated and were found 30 minutes later and they were dead. Again, this is not the outcome that we would like if we're trying indeed to make the patient safe. So, whilst we think that restraining the patient might indeed enhance its safety, we have found through research that it may be detrimental. So, we've said that every 30 minutes the nurse should observe and assess the patient. Every 2 hours, the patient must be totally taken out of the restraints. During this recess period, the patient's skin care should be assessed and also should be massaged, maybe lubricated with a lotion, doing something that encourages circulation to the skin. The patient's extremities should be exercised either passively or actively. Passive restraint would be that the nurse would take the joint through its full range of motion, at a minimum flexing and extending the joint 3 to 5 times. For active range of motion, we would simply ask the patient to take the joint through that range of motion 3 to 5 times. The patient should also be taken to the toilet. If the patient has had incontinence, obviously that should be cleaned up. The patient again should be offered the chance to go to the toilet. The patient should be given some type of nutrition during this 2-hour release, at a minimum a protein, carbohydrate snack, and some type of fluid. water, Coke, juice. Again, every 2 hours, the patient must be released. If the patient is considered an emergency situation at such a risk to themselves and the nurse is unable to contact the physician, the nurse may apply a restraint for behavior management. Obviously, you must follow all the rules for correctly applying the restraint, and they must document what was the situation that required restraining and why they were unable to contact the physician for an order. Within an hour, however, some physician or a nurse practitioner must come to evaluate that patient. It is therefore at that time that the practitioner or the physician will write the medical order. Again, alternatives to restraints are any other safety methods that can protect the patient. Prominent in many nursing homes, the use of bed alarms, sometimes called ambularms. These are battery-operated devices that may be a flat pillow-type device that's underneath the patient so that it alarms, it makes a sound if the patient's weight is redistributed, therefore alerting the staff that the patient may be getting out of bed. Some other alarms are only applied a band applied to the patient's leg, so that when the patient's leg position changes dramatically, again a signal the patient may be getting out of bed or standing from the chair, then the alarm goes off. The staff should make sure that the alarm is functioning when they place it, and every 2 hours they should come to the patient's room to actually do a safety check, just do a test alarm to make sure that the sound is still functioning and the sound is audible outside of the room. Again, this was a short integrity session on restraints. Understand that these should not be taken lightly. A restraint should always be the last resort. That when a patient is placed into restraint, the initial thing that the nurse must do is to get a medical order. Once the patient is placed into restraints, they should be constantly monitored at least every 30 minutes or maybe more often. Every 2 hours they should be released, and the medical order expires in 24 hours. During that time, constantly, the nurse should be reassessing if this restraint is still necessary. Thank you.